Good morning. I'm going to review what you need to know for your exam coming up on Monday morning. Let me make this a little bit bigger. So I made up a review sheet. I posted it under the mechanical ventilation module in RET 2714. And this is what you'll do to review for the exam. So you need to know the normal PaO2 and pulse ox saturation for a neonate breathing room air. You need to know what acrocyanosis is. You have to give examples of respiratory distress in a neonate. Let me close my door.
Good morning, Yvonne. Question, when you say examples of respiratory distress, do you mean like what causes it or what would it look like?
What it would look like.
Okay, thank you.
And then causes of A's, B's, and D's. Of course, that stands for apnea, bradycardia, and desaturation. So what causes these events to happen? You need to know the difference between a high flow nasal cannula and nasal CPAP. Why is one considered just high flow? Why is the other one considered CPAP? You need to understand why a 1 liter nasal cannula attached to an oxygen flow meter provides about 60% FiO2 to a neonate. Compare that to an adult. When we give an adult 1 liter per minute, they get about 24% FiO2. You need to list the different ways of providing nasal CPAP. We discussed using the ventilator for nasal CPAP. Bubble CPAP were the two that we used and discussed. You need to list the different ways of providing high flow oxygen therapy. So we use the OptiFlow nasal cannula in the lab. We also used Vapotherm. Is it a good idea to provide more than 8 centimeters water of CPAP to an infant? And the answer is no, because with that amount of pressure being delivered to the nose, it makes it difficult for the infant to exhale. So if they're not oxygenating well on ATA CPAP, increased FiO2s, at that point, it's indicated to intubate them and put them on a ventilator. So you don't want to go higher than 8 of CPAP for neonates. You need to know the best method for drawing a capillary blood sample from a neonate. And then what affects the accuracy of the sample. So in the best method, you're also going to look up where you're supposed to stick the heel. So you can't just say, oh, we use the heel to get our capillary gas. It has to be a specific place around the heel. If an infant goes home on an apnea monitor, how long do they have to be monitored? So make sure you look that up in your notes. With transcutaneous monitoring, why does the site have to be changed every 4 hours? Pretty sure that's in your notes. The sensor has to be warm so that it causes arterial blood flow in the capillaries. And then to get that arterial blood flow, you have to warm it up. But when you're warming up the skin, especially on the premature neonates, it can actually burn their skin. So every 4 hours, that site has to be changed to a different site. You need to know what gases you can monitor with transcutaneous monitoring. You need to know which values are most accurate. So is oxygen accurate when using transcutaneous monitoring? Is carbon dioxide accurate? And then there's a question at the end. Why would the transcutaneous monitor suddenly go from 55 torr up to 159 torr? And just to give you a clue, the amount of oxygen in room air is 159 torr. So maybe you can figure out why it's suddenly reading 159 torr. Why does a pulse oximeter read 2% higher than the saturation from the blood gas machine? So we talked about the blood gas machine is very accurate. It looks at several different wavelengths of light for hemoglobin. And then it accurately records the amount of hemoglobin with oxygen. The pulse oximeter only sees oxygenated hemoglobin and deoxygenated hemoglobin. So the percentage that gets reported is a little bit different. More accurate from the blood gas machine compared to the pulse oximeter. But the pulse oximeter in general, it reads 2% higher than what you get from your blood gas machine. All right, any questions on that? Who have I got?
No, no questions.
Okay. Okay, and then review your PowerPoint on mechanical ventilation. You'll have to choose the proper size laryngoscope blade for preemies, for a term infant, and then for 1 to 2 year olds. So look that up. As far as choosing the endotracheal tube, you need to know what size to use for premature baby, what size to use for a full term, and then what size to use for 1 and older than 1 year old. So there's a formula when for babies older than 1 year of age, and it's the age over 4 plus 4. So instead of knowing that they're premature, knowing that they're a full-term infant, if you're given the age, now you do age over 4 plus 4 to come up with the endotube size. And then when would you use a cuffed endotracheal tube on a neonate? So it's okay to use a cuffed tube on neonates. And typically what you're seeing though is the intensivist will start off with an uncuffed tube in all the babies. The cricoid cartilage is narrow enough so you don't get a complete seal, but close enough. However, if the percentage of leak around the endotube exceeds 30%, that's an indication that a larger endotube is needed or a cuffed endotube is needed. Oh, I already talked about this. It says calculate the proper size endotube for a pediatric. That's the age over 4 plus 4. I put a little note in here just to reinforce intubation skills. It says when intubating, remember that you advance the tube until the cuff, or if there's no cuff, there's a black line on the bottom of the endotube. So the cuff or the black line on the cuffless tube is past the vocal cords, and then you stop. So you don't intubate to get a certain lip mark. You visualize the tube going past the vocal cords, and when that black line is past the vocal cords, you stop. Then you make note of what the lip mark is. So don't intubate according to the lip mark. You check the lip mark after you've properly intubated, and then you see what the lip mark is. The lip mark will give you a way of keeping track of where the tube is, because once you secure the endotube and get an x-ray, now you've got your x-ray and your lip mark. So you'll know if the lip mark changes, that it's going to change on the x-ray also. So that's the purpose of recording the lip mark, is so that you can verify that the tube is not moving around. But you do not use that lip mark as a way of telling whether you've placed the endotube properly. The next question is, what is the approximate lip mark for a neonate that weighs 1 kilogram? So look that up in your notes. You're just going to add a number to that, and then you're going to come up with the lip mark. What is the approximate lip mark for a pediatric? And in your notes, it'll tell you to go by endotube size. So you multiply your tube size times 3. I'm giving you the answer. I'm supposed to make you look it up. Suction pressure used with neonates and pediatrics. So you have to know your proper suction pressure. When using a ventilation device to ventilate a neonate, what device needs a mask seal and proper flow to function? So the different ventilation devices that we use, one of them was a flow inflating ventilation device. One was a self-inflating or bag valve mask, we call it, self-inflating device. And the other one was the NEOT. So remember with the self-inflating bag, as soon as you lose the seal, you lose all the flow in the bag. So that needs a proper mask seal in order to function. Next question, how do you adjust peak pressure on the NEOT? Do you adjust the blue valve around the port that you cover for inspiration? Do you change the flow meter? Do you change the pressure setting on that gauge near the flow meter? So you have to know how to adjust peak pressure on the NEOT. The next question is, what ventilating pressure is acceptable? So I gave you a range of acceptable pressures as 18 to 20 centimeters of water. And then also told you we want to make sure that pressures stay below 25 centimeters of water. Okay, and then there's a true-false question thrown in here. And the true-false question reads, covering the hole on the NEOT is done to deliver CPAP to the baby. Is this true or is this false? So the answer is false. So when you're covering the hole on the NEOT, you are giving a positive pressure breath. CPAP is during exhalation or not covering the hole. So just holding the mask over the baby's face and not covering the hole is how you deliver CPAP with that device. But once you cover the hole, now you're delivering a positive pressure breath. And it is okay just to have the mask over the face with the NEOT, and just let the baby breathe the positive pressure. So that's called mask CPAP. Next question, what are the indications for mechanical ventilation? So why would you decide that a baby needs to be intubated? So on the exam, you'll be given a scenario and say, what do you suggest? So you have to know what the indications are that the baby needs mechanical ventilation. And then describe the mode for TCPL, and that stands for time cycled pressure limited mode. But time cycled pressure limited, that's what we use to describe a pressure control breath. We say that it's time cycled pressure limited. So the difference between TCPL and standard pressure control has to do with the flow waveform. So in pressure control, we get an automatic decelerating flow wave pattern where there's a lot of flow at the beginning of the breath and then it slows down. With TCPL, you set your flow rate and it's delivered at a constant flow rate. So that's the difference between pressure control and TCPL. And next is to describe volume guarantee. So we know that volume guarantee is just like giving a PRVC breath, where the pressure will vary from one breath to the next to target a tidal volume. In this mode, it doesn't wait. It doesn't alter it by 3 centimeters of water. I think it's 1 centimeter water at a time. And if the volume is delivered before inspiration ends, it will stop the I time so that more volume doesn't get delivered during that breath. So volume guarantee is going to adjust pressure to target a tidal volume. And also during inspiration, if the volume has been delivered, inspiration will end. Next, it says, what are starting vent settings for placing a neonate on mechanical ventilation? So you need to pick a mode, a rate, you're going to mention either volume guarantee or pressure control or TCPL volume guarantee. And then you're going to mention if it's volume, you mention the amount of volume that you would use to ventilate a neonate, or if it's pressure, what kind of volumes are you trying to target with the pressure? And then of course, FiO2 and PEEP. What is the difference in using a flow sensor in the ventilator circuit versus not using a flow sensor in the ventilator circuit? So you guys have had this in the lab for the last 3 weeks. We talked about it in lecture. So I think you're good to go on that one. Calculate compressible volume that stays in the vent circuit. So it'll give you the compliance of the circuit. It'll give you the delta P. It'll give you the tidal volume, the exhale volume, and ask you what was actually delivered to the neonate's lungs. So you have to be able to calculate that. How does a leak around a cuffless endotube affect mechanical ventilation? So you're going to mention how you could get auto triggering occurring when there's a leak. If the leak is big enough, it will cause auto triggering. So you may have to adjust your sensitivity setting and make it less sensitive. That helps. With pressure support breaths end when flow slows down. But with a leak, flow doesn't slow down. So the ventilator doesn't know when to end the pressure support breath. And it'll typically default to about 5 seconds, and then the ventilator ends the breath. But you may have to adjust your inspiratory cycle off percentage to a higher percentage to kind of help and kind of force that inspiration to end because of the leak. And then the other thing is you may want to turn on leak compensation. The ventilator will say, okay, let me recognize the leak. Let me send in extra flow to compensate for that leak. And then it kind of subtracts the air going out the leak from the numbers that you see. So it more accurately reports the numbers going into and out of the lungs when you're compensating for the leak. And remember, leak compensation is not the same thing as circuit compensation. So those are two different things. If a newborn is on bubble CPAP and the FiO2 is increased up to 0.40 to maintain oxygenation, what could be the issue? So when you're using 40% or more oxygen on a newborn, there's a good chance that a lot of their alveoli have collapsed, probably because their surfactant isn't mature enough and it's not keeping the alveoli open. So that's a clue. If you're using increased FiO2s, that surfactant therapy needs to be delivered. Okay, so that was all the questions that are going to prepare you for the exam. Is there anything I can go through in more detail, help you to understand it?
No, I don't think so. I think everything is in our notes in the PowerPoint.
All right, perfect.
Thank you.
You're welcome. Goodbye.